السلام عليكم. دكتور عمار خير من مستشفى كليفلاند كلينيك ابو ظبي. سعيد جدا بحضوري معاكم واشكر بروفيسور عزت على الدعوه الكريمه وسعيد جدا بشوفتكم. And I've been given the task for speaking on the code revolution. How far can it go? الأجندة بتاعت النهارده I'll try and keep it brief, but we're going to talk on hazards of conventional polypectomy and the rationale for cold, quick guideline update, performance characteristics of cold polypectomy and cold EMR, and how you can maximize the effectiveness of your treatment, and what are the emerging applications for cold resection. Our aim with polypectomy is to prevent colorectal cancer, intracolorectal cancer, and colon cancer-related mortality. So we need to be safe, precise, efficient, effective, minimize invasiveness, and minimize patient harm, specifically bleeding and perforation, avoid polyp recurrence, and avoid surgery and its associated morbidity and mortality. Polypectomy reduces colon cancer, but arguably it's the most the most complications of polypectomy arise from the use of hot snare diathermy, and these are many, but specifically delayed bleeding, deep neural injury and perforation, and also incomplete resection. All snares are not created equal, so although these snares look all the same, but they're very different in their characteristics, and 3 of them here are from the same company, but dedicated cold snares are probably the best way to maximize your effectiveness in cold resection. So they have specific characteristics. The wire of the snares needs to be thin, stiff, usually 0.25 to 0.32 diameter. The open snare diameter is about 9, 10, and there's some manufacturers who have 15 millimeter. But the polymer of the snare catheter need to be from a resistant semi-rigid catheter, so you can have a very firm push down and not to have the catheter bent, so you don't really slip when you're resecting polyps. Polypectomy in 2023 is lesion specific, so we predict the pathology based on optical diagnosis, whether it's serrated adenoma or if it's a cancer, and then depending on the size, the location, we can predict the risk for covert or hidden submucosal invasive cancer, and then decide based on also morphology whether you proceed with cold, piecemeal, en bloc, ESD, EMR, or EFTR, or go straight to surgery. There are 2 excellent guidelines, the European from 2017 and the US Multi-Society Task Force from 2020. And they're more or less the same, but basically for polyps up to 9 millimeters, so diminutive and small, cold snare polypectomy is the right treatment of choice. Same thing with the American guidelines, but they also go one step further, where they recommend also or allow for cold or hot snare polypectomy with or without injection, so cold EMR, for lesions up to 20 millimeter in size. So for diminutive polyps, strong recommendation, high quality evidence. All of them should be removed by cold snare polypectomy. And this is a quick video. In the interest of time, I'll skip some of the videos because I only have less than 10 minutes to talk. But this is a dedicated cold snare. So this is a diminutive lesion, about 2 millimeter in size. You push down firmly, make sure that the snare is parallel to the wall, push the catheter while you're controlling the snare closure with your assistant. And the aim is to get a sunny side up egg like that, where you have a very generous margin of normal tissue surrounding it. This is the same concept with a smaller size. I'll skip on that video in the interest of time. So what are the limitations of cold resection? So we know that you can have cold snare stalling, which is an issue, especially when you get into 6 millimeter in size and above. But this is a very common, very benign phenomenon that we face. They come in different shapes and sizes, but this is in a study that our colleagues did in Australia, there is no risk for any residual neoplasia on the tip, but you may face that when you're doing large colonic EMRs, especially if it's a high-grade or tubulovillous adenoma. So the constituents of that protrusion is mainly muscularis mucosa and submucosa. It's usually more common, as I said, when it's 6 millimeter in size. Frequency is about 30% of your polypectomies, and you don't need to clip it. The other side of the equation, that when we resect cold, the limitation with cold that you're only getting a mucosa and muscularis mucosa, so you don't get any submucosa, so there's limitation of depth and width also, compared to hot snare polypectomy, where you have also submucosa in your resection. And this is relevant when you're dealing with a lesion that has risk for covert cancer, but in most lesions we face, these are benign, very low risk of cancer within diminutive and small polyps, so cold snare is fine. The advantages of cold that it's an efficient, quick, safe, technique. There is almost zero risk for delayed bleeding, zero risk for perforation, and it's very safe with antithrombotics, which I'll share with you shortly. For those who are interested in cold techniques, we have an article that we wrote a few years ago called The Cold Revolution, and I'm happy to share it with my email at the end. But this is our proposed technique for cold snare polypectomy. So we bring the lesion from 3 o'clock to the 6 o'clock because this is where your working channel is. You perform optical diagnosis. This is nice type 2, high confidence, so it's an adenoma, zero risk for cancer. You place the snare, resect it with a margin of normal tissue, and then you examine your resection site. So for non-pedunculated 10 to 19 millimeter, the guidelines allow you for cold resection. And just quickly here, for this, probably the best study for these sized polyps, where they randomized hot snare polypectomy versus EMR versus cold snare polypectomy versus cold EMR, where the outcome showed that the cold resection had less incomplete resection rate, and it was proven to be not inferior and was more efficient than hot snare resection. This is a quick example for a large sessile serrated lesion. Nice type 1, we inject it to delineate the margins. You start putting your snare, having a generous frame of normal tissue. Usually the proportion will be, in my practice, is 30 to 70. Once you get into the submucosa plane, then you just repeat the same step meticulously until you reach a full resection. Same thing with adenomas. So this is a very subtle medium to large size adenoma. But once you inject it, you can see the margins, and this is the end result. And in long-term follow-up, you can see after almost a year, there's a nice clean scar with no recurrence of the lesion. So what about large lesion, more than 20 millimeter? EMR is the preferred therapeutic option. However, there is an increasing evidence that we can actually perform safely and effectively cold EMR for all serrated lesions, regardless of their size, as long as they don't have cytological dysplasia. And there is an increasing role for the use of cold EMR for selected adenomas, mainly the flat ones without risk for covert or overt submucosal invasion. These some studies, including a couple of our own that we did and showed excellent results with cold EMR. So how can we predict morphology? How can we predict, based on morphology, predict covert submucosal invasive cancer? So you look at the polyp, you assess it. There's no features of cancer on the surface, but you may get a surprise on the histology that there's a cancer. So these lesions you want to try and avoid and preferably resect them en bloc with a more advanced resection technique. But basically, I'll just skip in the interest of time. If you have a bulky lesion, non-granular, in the distal location, the risk goes from less than 1% to almost 22%. So these are the lesions that need to do en bloc resection with an ESD style. Again, here all I'll say that if the lesion is flat and you're doing an optical assessment, your chances of missing a cancer is 6 in 1,000 compared to 6 in 100 in a bulky lesion. So if you assess it with a flat lesion, you're actually rarely going to face a cancer. So these kind of extensive lesions, these are not suitable for cold EMR. And bulky lesions like these in the distal location, here this is a high risk for covert or hidden cancer, so we perform an en bloc EMR, not a cold EMR. And this is a lesion with a high risk JNET type 2B, so high risk for cancer, covert cancer, so we perform an ESD. And this lesion here is a lesion of superficial invasion in a patient that declined surgery, so we perform a intramuscular dissection ESD to cure the patient. In the interest of time, I think I'll have to skip on some of these videos, but I'll show you here. So this is a large tubulovillous adenoma. This was presented at the ESGE last year. So here we're injecting the lesion. And then systematically we resect the polyp. So including a margin of normal tissue, pushing the snare firmly, using a dedicated cold snare, and ensuring that you get a full resection and this is the end result. And on follow-up, and this patient actually had 3 years with us, no recurrence. Sorry, I've lost my screen. Can somebody? Huh? I cannot see the screen.
Give him 2 minutes.
Oh, sorry. Okay, sorry. So I'll just skip to the final slide now. There is an increasing role for cord resections for patients on antithrombotics, duodenal lesions, FAP lesions. So in summary, increasing role for an emerging role for cord resections, including up to more than 20 millimeter, FAP patients, non-ampullary duodenal adenomas, and patients on anticoagulants. And thank you.
Thank you, Dr. Ammar, for this elegant presentation. I'll take comments from the chairperson first. Any comment from the chairpersons?
Yes, Dr. Ammar, I would like to ask you about the occurrence of bleeding after such cold snaring for large polyps.
Yes.
Do you have any occurrence of post-bulbectomy bleeding?
In the duodenum, you mean, or? Sorry, doctor, in the duodenum?
Bleeding after excision of large lesions.
Yes, yes. So because the cold technique is confined to the mucosa and the muscularis mucosa, so we're not injuring the submucosal vessels, so the risk of delayed bleeding is actually 0. Even in patients on anticoagulants, it's only about 19% in the randomized control trial that we did that you actually need to use clipping, but delayed bleeding was 0. Intraprocedural bleeding on patients with anticoagulants is about 19%, where it would not stop after 2 minutes, that you need to put 1 or more clips, but otherwise it's extremely safe. And risk of bleeding after going home is 0. Yeah.
So what's the advance of cold snaring and hot snaring? Can you tell us which of which?
Yes. So
why you choose this or that?
Yes, for cold snaring is to avoid the complications of diathermy. So we're avoiding delayed perforation, delayed bleeding, and deep mural injury and post-polypectomy syndrome. So when we use the cautery, you automatically incorporate a delayed thermal effect that continues to go deep into the submucosa. That's why the patient, up to 2 weeks, they can come back with you completely eliminate that.
If you have bleeding, would you use the coagulation or just put clip?
Hidden cancer, you mean?
After your excision for large lesion, for example.
Oh, yes, sorry.
Says that you had bleeding.
0, yeah. So actually, if you resect cold, that's another advantage. It's quick and cheap. You don't need to clip any of the defects. You keep them open. Even with patients who are on anticoagulants, although the studies are mainly on lesions up to 10 millimeter, you only need to clip 19% of the time, but 81% of the time you don't need to put a clip, and we've done hundreds of patients, and in our experience in Abu Dhabi, we've done almost thousands of patients. But for large lesions, at the moment, our protocol, because of the expectations of our patients and the community, we are using a universal clipping strategy. So we still put a clip even though there is no bleeding, just to until I guess the community and the GI community are ready for it. But at some point we need more studies to see which cases need clipping on anticoagulants with EMR and which ones do not need that.
You mentioned diminutive polyps. Are diminutive polyps always benign, or you should remove and
yes, thank you.
do examination, histopatology?
Yes. So the risk of cancer within them, if you assess them, is extremely, extremely rare. It's about 1 in 5 to 6,000. So actually now even the ASG has a resection and discard strategy for adenomas that has been talked about for many years, and diagnose and disregard for diminutive lesions, hyperplastic and rectosigmoid. And actually I do that in my practice selectively for patients who cannot afford paying for the histology, or because of the cost. But at the moment, it's not universally applicable. I think we still need more reassurance to reassure our patients, our payers, and the community that we can do it. But before you do that, you have to really show that you are skillful to do it. So you have to go through a lot of steps and to be monitored. Yeah.
Thank you very much. One small question about in the presence of the magnifying scopes and BMI, etc.,
Yes,
etc.,
yes.
there is no need to take biopsy or do polypectomy if you suspect, if you are, you should be proved, you should be sure that this is juvenile,
Yes.
not tubular or whatever.
Yes.
So I saw that you removed very simple polyps by cold snare for, as Tahir said, it may bleed and you may have to do cautery or apply clip.
Yes.
So what's your comment on this?
Yeah, so these diminutive polyps, if they're adenomas, we still have to remove them because they will progress to cancer in the future. And actually the recommendation from all guidelines that we still have to remove all diminutive polyps. That's the first thing. The second thing is, if you're using a cold technique, you will not get a bleeding and you will not need to clip unless the patient is on anticoagulants. So I guess that's the rationale for the removing diminutive adenomas, because based on and we also at the moment still need to remove them and send them to histology, because based on the histology, confirmation of the adenomatous histology, then you can decide based on the size and the histology when should the patient get their next colonoscopy. Yeah.
Thank you very much.
Thank you.
Dr.
سؤال.
Dr.
لا،
Ibrahim has a question.
Yes. You speak about cold or hot. You prefer sides, if you have a side on the left side or right side with the colon, so you prefer cold snaring on the right side or the left side? It's because right side may be some dangerous if you
Yes.
use coagulations or so, because we have many cases of right side sessile polyp that around the cecum or around the ileocecal valve. So if you have a right side and it can be removed by cold snaring, it's better.
Yes.
And the left side, we can use both.
Thank you,
But for
Professor.
the right side,
Yeah.
this is actually right.
Yeah, thank you, Professor Ibrahim. Yes, I'm aware of the, so you're quite right that the risk of delayed especially post EMR, but also with conventional polypectomy on the right side, there is an increasing risk for delayed bleeding. The bleeding risk in that side goes up to 12%. So that's why now it's become a standard of care. If you are using conventional EMR with cautery, you should ideally close all the defects. However, this is the advantage of cold, that you actually remove. I mean, I remove up to 120 millimeter size sessile serrated lesions in the right side, absolutely no clipping. And they do ooze as you're cutting, because obviously you're cutting, but the bleeding will stop within less than a minute, up to 2 minutes, and then you don't need to put any clips, because as the time goes by, the hemostasis will be more stable and there is no risk for delayed bleeding because you have not used cautery to injure the submucosal vessel.
Second, how you know that the right side polyp large like that,
Yeah.
you showed it by cold snaring, there is no submucosal invasion. Only elevation. If you elevate it, so it is sure there is no invasions.
Thank you. So the lifting sign, actually, I
It's enough?
discourage it. I discourage it, respectfully. It should be on optical diagnosis. So if you use a NBI or BLI classification, you should know for sure if this is adenoma, hyperplastic, sessile serrated lesion, or has a risk for cancer. If it's a cancer, then you shouldn't be removing it. And submucosal injection, if it doesn't go, could be from fibrosis, or if you haven't found the right plane. But especially for flat lesions, optical diagnosis is really excellent.
This is the most important thing, so what you said,
Yeah.
that because all the people should be understand that's not normal in the scope.
Yeah.
It should be at a very high level on the scope, because by optical, you can say this can be removed by cold, or this can be removed
100%.
by hot snare. So this is very important, but not by normal endoscopes.
Yes.
This is something like what Professor Stark said, that by new advantage of the endoscopy, you can diagnose this is not submucosal invasion, so you can remove it.
Yes.
So this is very important what you said, to the people to understand that. Thank you very much.
you so much.
And
Thank
then
you,
we go
our
second one.
chairpersons, and